Welcome to our video on macrocytic anemias. Let's get started. In this lecture, we're going to cover megaloblastic macrocytic anemia by discussing vitamin B12 deficiency anemia and folate deficiency anemia. Then we'll move on to non-megaloblastic macrocytic anemia. All right, let's get started. For each of the disorders, we'll cover the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. Let's begin with vitamin B12 deficiency. B12 deficiency results in macrocytic megaloblastic anemia. Let's break this down. Macrocytic means that the mean corpuscular volume, or MCV, of RBCs is greater than 100. These macrocytic RBCs are known as macrocytes. Megaloblastic means that the anemia is characterized by the presence of megaloblasts, which are large nucleated red blood cells with non-condensed chromatin. This image depicts megaloblasts, which is the hallmark finding of megaloblastic anemia. Note the presence of nuclei and large cytoplasm of these cells. All right, let's briefly review the absorption of vitamin B12, as this will help you understand the etiology and risk factors of B12 deficiency. Dietary vitamin B12 is normally bound to proteins in food and is provided by food products of animal origin. Hence, vegans who don't supplement B12 can become deficient in this vitamin. Pepsin and an acidic pH in the stomach degrade these dietary proteins and release vitamin B12. Thus, decreased gastric acid release, for example, due to chronic use of PPIs, can increase the risk of vitamin B12 deficiency. Vitamin B12, that is now free, then binds to one of the 3 vitamin B12 binding proteins, known as R binders, or simply R protein. These proteins are produced by the salivary glands. In the duodenum, the pH is less acidic, permitting pancreatic proteases to degrade the R protein. Hence, pancreatic insufficiency can predispose to vitamin B12 deficiency as well. This frees up vitamin B12, which then binds to intrinsic factor produced by parietal cells. An autoimmune reaction against parietal cells results in pernicious anemia, which is the most common cause of vitamin B12 deficiency. In the terminal ileum, the vitamin B12 intrinsic factor complex is recognized by receptors for absorption. Diphyllobothrum laudum, which is a tapeworm, can dissociate vitamin B12 from the B12 intrinsic factor complex and thus impair its absorption. Finally, Crohn's disease or any other pathology of the terminal ileum itself can result in vitamin B12 deficiency as well. The association of vitamin B12 deficiency with Diphyllobothrium laudum infection and Crohn's disease is by far the highest yield for step 2. Now let's dive into the pathophys of this macrocytic megaloblastic anemia. To understand the pathophysiology, we need to know that vitamin B12 is needed for proper DNA synthesis, and that vitamin B12 deficiency results in impaired DNA synthesis. Proper DNA synthesis is needed for nuclear maturation, so vitamin B12 deficiency effectively impairs nuclear maturation, which is necessary for RBC maturation and division. While nuclear maturation of red blood cells is impaired, cytoplasm maturation isn't affected by impaired DNA synthesis. So the end result is increased cytoplasm content with immature nucleated red blood cells. As we mentioned on the previous slides, these cells are called megaloblasts. Now, recall that immature nucleated red blood cells are larger than mature red blood cells. Similarly, these large immature nucleated megaloblasts are larger than normal red blood cells. Hence the name megaloblastic macrocytic anemia. The impaired DNA synthesis and defective nuclear maturation also leads to abnormally large hypersegmented neutrophils. Here you can see the image of hypersegmented neutrophils. These refer to neutrophils with 6 or more lobes. The presence of more than 3% of neutrophils with at least 5 lobes is also sufficient. However, the image on your exams should be pretty straightforward, and other features of megaloblastic anemia should be present as well. Next, here is a peripheral blood smear showing larger than normal red blood cells, known as macrocytes. Before I go any further, I'd like to mention that this image was contributed by Ambos. So thanks to our partnership with Ambos, I can highlight several important features of megaloblastic anemia. To have a full understanding of the pathophysiology, we need to review some relevant biochemistry. This review will also help you understand diagnostic workup and clinical features better. Notice how vitamin B12 is needed for the proper functioning of methionine synthase and methylmalonyl-CoA mutase. Methionine synthase converts homocysteine to methionine. Impaired function of methionine synthase in vitamin B12 deficiency results in increased homocysteine levels. Increased homocysteine levels, in turn, induce endothelial damage and increase the risk of thrombosis. Methylmalonyl-CoA mutase, on the other hand, converts methylmalonyl-CoA into succinyl-CoA. Decreased function of methylmalonyl-CoA mutase results in accumulation of methylmalonyl-CoA and its precursor, propionyl-CoA. The accumulation of these substances impairs myelination of nerve fibers and induces myelin degradation. This can lead to neuropathy, dementia, and involvement of neuronal pathways in the spinal cord. We'll discuss the clinical manifestations in detail in the upcoming slides. A 50-year-old woman with rheumatoid arthritis and chronic GERD presents to her primary care provider with a chief complaint of fatigue for the past several months. Physical examination is notable for tachycardia and diminished sensation to light touch and vibration in her lower extremities. Laboratory studies show a hemoglobin of 9, an MCV of 110, and elevated homocysteine levels. What is the differential diagnosis for this patient's anemia? All right, based on the labs, this patient has a macrocytic anemia with elevated levels of homocysteine. Both folate deficiency and vitamin B12 deficiency can result in these lab findings. Folate deficiency is possible in this patient because she has rheumatoid arthritis, which is often treated with methotrexate as a first-line drug. And methotrexate can cause a folate deficiency. Vitamin B12 deficiency is also possible if this patient developed pernicious anemia, which recall is an autoimmune disorder that can lead to vitamin B12 deficiency. Since she already had an autoimmune disorder, which was rheumatoid arthritis, she's likely to develop another one. Alternatively, because this patient has a long-standing history of GERD, she has most likely been taking a proton pump inhibitor for many years. As such, vitamin B12 deficiency may develop due to chronic daily use of a PPI. The key in distinguishing vitamin B12 deficiency from folate deficiency is the presence of neurological symptoms. Recall that vitamin B12 deficiency can lead to neurological symptoms, such as diminished sensation to light touch and vibration, as seen in this patient. Folate deficiency, on the other hand, does not result in neurological symptoms. So in answer to the question, the differential diagnosis includes folate deficiency and vitamin B12 deficiency, but because of her neurological symptoms, B12 deficiency is more likely. Now let's talk about the clinical features of vitamin B12 deficiency. Macrocytic anemia can result in classic signs of anemia, such as fatigue and pallor. Patients may also present with angular stomatitis, glossitis, and symptoms of peripheral neuropathy, such as pain, numbness, tingling, and weakness. Neuronal toxicity can also result in dementia and subacute combined degeneration. This image depicts angular stomatitis, which is also known as angular cheilitis. Note that this is characterized by cracked, scaly, painful corners of the mouth that can lead to a burning feeling of the lips and mouth. Let's show the tracks involved in subacute combined degeneration visually and briefly review the associated clinical features. As we mentioned on previous slides, vitamin B12 deficiency can result in myelin degradation, and myelin degradation involving the dorsal columns of the spinal cord results in decreased sensation of vibration and proprioception. The involvement of the spinocerebellar tracts results in ataxia, and the involvement of the lateral corticospinal tracts results in spasticity and hyperreflexia. So in short, if a patient with macrocytic anemia presents with a constellation of neurological findings, think of vitamin B12 deficiency. Next, let's cover the diagnostics of vitamin B12 deficiency. First, a complete blood count or CBC should be done, which often reveals anemia with macrocytosis. A peripheral blood smear reveals macrocytes, megaloblasts, and hypersegmented neutrophils. Note that these findings aren't specific to vitamin B12 deficiency and could be present in folate deficiency as well. Hence, serum B12 and folate levels should also be obtained. If serum vitamin B12 is decreased and folate is normal, a diagnosis of vitamin B12 deficiency can be made. If folate and serum vitamin B12 levels are borderline, serum homocysteine and methylmalonic acid levels should also be obtained. Increased homocysteine and methylmalonic acid levels are suggestive of vitamin B12 deficiency. Lastly, let's discuss the treatment of vitamin B12 deficiency. Intramuscular hydroxycobalamin is preferred over oral formulations of vitamin B12 because this helps ensure absorption and compliance. Patients are recommended to follow a diet rich in vitamin B12, which includes eggs, red meat, fish, and fortified grains. However, this is just an adjunctive measure, and vegan patients may choose to receive B12 supplementation without dietary changes. All right, here's our overview slide again. Now let's move on to discuss folate deficiency anemia. And just like with vitamin B12 deficiency, we'll discuss the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. Let's begin by discussing the risk factors of folate deficiency anemia. Drugs, particularly anticonvulsants like phenytoin and folate antagonists such as methotrexate, are very common risk factors for folate deficiency. Malnutrition is another important risk factor and is usually seen in patients who consume a diet low in fruits and vegetables. Unlike vitamin B12 deficiency, for which stores in the liver can last for years, folate stores are sparse, and deficiency can develop in months. Finally, anything that increases a folate requirement can also lead to a folate deficiency. This would include, for example, pregnancy and chronic hemolysis. All right, let's try another question. A 40-year-old female presents to her primary care provider for regular follow-up. She has a history of tonic-clonic seizures, which has been well controlled with phenytoin for the past several years. Physical examination is unremarkable. Routine laboratory workup is notable for a hemoglobin of 7.8 and an MCV of 112. What is the next best step in management? All right, the most commonly tested etiologies of macrocytic anemia are either folate deficiency or B12 deficiency. In this particular case, the patient has developed a macrocytic anemia in the context of chronic phenytoin use, which is used to manage her seizures. Recall that phenytoin has multiple noteworthy side effects, including a possibility of folate deficiency. As such, the next best step in management would be to order serum folate and B12 levels. This patient will likely need folate supplementation to address her anemia. All right, now let's move on to discuss the clinical features. Patients with a folate deficiency commonly report signs of anemia, such as fatigue, dyspnea, pallor, headache, and palpitations. And similar to patients with a vitamin B12 deficiency, these patients can also develop glossitis. The key to differentiating these conditions clinically is that patients with a folate deficiency anemia have no neurologic symptoms. It's also worth noting that folate deficiency during pregnancy increases the risk of neural tube defects. Even though the exact mechanism of how this occurs is unclear, the association is well established, and supplementation of folate in the early stages of pregnancy is crucial. Here we can see an illustration of glossitis, which again can be present in either folate or B12 deficiency. Glossitis literally means inflammation of the tongue. Patients often develop oral symptoms such as burning, paresthesias, and pruritus. Now let's dive into the definition and pathophys of folate deficiency anemia. Low folate results in low levels of tetrahydrofolate, which is a folate metabolite required for DNA synthesis. As we mentioned previously, impaired DNA synthesis results in megaloblastic anemia and hypersegmented neutrophils. But because folate is not required for the proper functioning of methylmalonyl-CoA mutase, an accumulation of methylmalonyl-CoA and propionyl-CoA doesn't take place in folate deficiency. Hence, in contrast to vitamin B12 deficiency, there is no demyelination of nerve fibers. All right, now let's move on to the diagnosis. To start with, a peripheral smear and a CBC are ordered and typically reveal hypersegmented neutrophils and an increased MCV, respectively. As a lot of the manifestations overlap with B12 deficiency, serum folate and B12 levels are obtained. Isolated low folate levels can confirm the diagnosis, but if the results are not conclusive, for example, if the labs are borderline, homocysteine and methylmalonic acid levels should be ordered. Increased homocysteine and normal methylmalonic acid levels are suggestive of a folate deficiency. Here's another image depicting hypersegmentation of neutrophils. Again, this finding can be present in either folate or B12 deficiency. Now let's cover treatment. Oral folic acid is given for treatment, as folic acid deficiency is usually related to malnutrition. Individuals who can't tolerate oral intake, for example due to unremitting vomiting, can receive IV folic acid. As we mentioned on the previous slides, folate deficiency in pregnancy increases the risk of neural tube defects. Therefore, folic acid supplementation is recommended daily before and throughout the pregnancy. All right, returning to our overview slide, now let's move on to discuss non-megaloblastic macrocytic anemia. Again, we'll cover the definition, pathophys, risk factors, clinical presentation, diagnosis, and management. Non-megaloblastic anemias are macrocytic anemias that are not related to impaired DNA synthesis. Thus, no hypersegmented neutrophils or megaloblasts are present. Now let's discuss the risk factors. In alcoholic patients, macrocytic changes can occur even in the absence of vitamin deficiency due to the direct toxicity of alcohol on the bone marrow. Patients with liver disease and hypothyroidism can develop non-megaloblastic macrocytosis secondary to increased lipid deposition in the membrane of circulating red blood cells, which increases the red blood cell membrane surface area. Non-megaloblastic macrocytosis can also result from accelerated erythropoiesis due to increased production of reticulocytes that are larger than mature red blood cells. Finally, multiple myeloma and myelodysplastic syndromes can also result in macrocytic anemia, likely by compromising the function of the bone marrow. All right, now let's discuss the clinical features. Symptoms often include typical manifestations of anemia, such as dyspnea, fatigue, and conjunctival pallor. Patients can also develop symptoms related to the underlying disease, for example, scleral icterus in liver disease. This image depicts scleral icterus, which can be one of the manifestations of liver disease, a common cause of non-megaloblastic anemia. Now let's move on to discuss diagnosis. A peripheral blood smear, CBC, vitamin B12, folate, and reticulocyte count are the initial tests recommended for the workup of non-megaloblastic macrocytic anemia. These tests help us rule out other potential causes and evaluate the blood for the presence of megaloblastic changes. Non-megaloblastic macrocytic anemias with a low reticulocyte count should increase our suspicion for liver disease, hypothyroidism, alcoholism, myelodysplasia, and multiple myeloma. A high reticulocyte count indicates that the anemia is likely due to hemolysis. Further workup is directed at identifying the underlying cause, for example, obtaining liver function tests and thyroid function tests. Finally, let's cover the treatment. It's important to treat the underlying condition. So for example, in the case of alcoholism, this would mean abstaining from alcohol. And in the case of hypothyroidism, it would mean thyroid hormone supplementation. Here is an AMBOSS algorithm showing the diagnostic workup of anemias. We can see that in this image, anemia is broken down into microcytic, normocytic, and macrocytic anemias. So the first step is to measure the MCV, which we do with a CBC. And if the MCV is greater than 100, we're in the category of macrocytic anemias. Next, we'll want to look at a blood smear. And if the blood smear shows megaloblastic changes, then we think about a folic acid or vitamin B12 deficiency. If there are no megaloblastic changes, then we think about other diseases such as reticulocytosis, liver disease, alcohol use, myelodysplastic syndrome, hypothyroidism, and multiple myeloma. All right, let's finish up with a question. A 50-year-old woman is admitted to the clinic with a chief complaint of fatigue and weakness. She says she first started feeling fatigued 3 months ago, and she started noticing weakness and tingling in her legs over the past 2 weeks. She underwent a Roux-en-Y gastric bypass procedure several years ago and has been consistently losing weight since then. Review of systems is otherwise negative. Vital signs are within normal limits. Physical examination is notable for mucosal pallor, 3 out of 5 strength in the lower extremities bilaterally, and brisk patellar reflexes bilaterally. When the clinician stretches the soles of her left and right foot, her toes flare out. Laboratory workup is likely to reveal which of the following. Pause the video and consider these options. Okay, the correct answer is E. Let's examine the question stem one more time to understand why. In this vignette, we're told about a woman who recently underwent a gastric bypass procedure and is now presenting with fatigue and weakness. Her physical exam is notable for mucosal pallor, which could indicate anemia. It also is notable for diminished strength in the lower extremities, as well as brisk patellar reflexes and a positive Babinski reflex. Clearly, this patient is experiencing some sort of neurological problem in the context of her likely anemia. As we discussed earlier, a history of gastric bypass in the context of anemia should always prompt suspicion of vitamin B12 deficiency. B12 deficiency is especially likely given that this patient is experiencing neurological symptoms. Hence, when we examine the table on the following slide, we'll be looking for a pattern consistent with vitamin B12 deficiency. Option A presents a laboratory pattern consistent with normocytic anemia. This is because the hemoglobin is low and everything else is normal. An anemia like this could be seen in the setting of acute blood loss, which is not the case in this patient. Option B presents a laboratory pattern consistent with a microcytic anemia. Given that the ferritin is also low, option B is presenting a case of iron deficiency anemia. Though this may happen in patients with a history of gastric bypass, it would not be associated with neurological symptoms, as was seen in this patient. Option C presents a case of macrocytic anemia, but with normal levels of homocysteine and methylmalonic acid. This laboratory pattern of macrocytic but not megaloblastic anemia can be seen in patients, for example, with alcohol use or liver disease, and this is not the case in our patient. Option D presents a case of macrocytic anemia with elevated levels of homocysteine but not methylmalonic acid. This is a case of megaloblastic anemia due to folate deficiency. Finally, option E presents a case of macrocytic anemia with elevated levels of homocysteine and methylmalonic acid. This is a pattern consistent with a megaloblastic anemia due to a vitamin B12 deficiency and is thus the correct answer. And that concludes our presentation on macrocytic anemias.